What's up, everyone? It's Miles here from bootcamp.com, and today in pulmonology, we're going to start our chapter on special pathology topics. So in this chapter, we're going to be going over those last high-yield conditions that pertain to pulmonary pathology. So in today's video, we're going to be going over deep venous thrombosis, or DVT, and pulmonary embolism. So we're going to start off by talking about deep venous thrombosis. Now, as the name suggests, a deep venous thrombosis is a thrombus that has formed in the deep veins, and usually it's going to be the deep veins of the leg. Now, this thrombus can form in any of the deep veins, but classically, especially in a boards question, it's going to be the deep veins of the leg. So if we take a look at this diagram over here, and we're taking a look at the deep veins of the leg, and we just zoom in on a vessel here, we can see that a clot has formed in the deep veins of the leg. This is a DVT. Now, there are three major things that makes an individual susceptible for developing a DVT, and these are described in Virchow's triad. So the first one, and in my opinion the most high yield, is going to be stasis. So if we take a look at these two blood vessels here, when blood is moving fairly quickly, this is usually not going to result in clot formation. However, if blood is moving slowly or is stagnant, this tends to activate coagulation factors, which is going to lead to the initiation of clot formation. In the two classic scenarios, especially in boards questions where we get blood stasis, is going to be number one, long travel. So this can be things like a long plane ride or a long car ride. And number two is going to be post-surgery, especially orthopedic surgeries, usually of the hip or the leg, where the lower extremities are immobilized. So in both of these scenarios, we're really not moving around that much, and so blood starts to pool and become stagnant in the lower extremities, and this could lead to coagulation and DVT formation. Next, of course, if someone is in a hypercoagulable state, this could lead to clot formation and a DVT. And one of the classic scenarios is someone that has adenocarcinoma, because the mucin that's produced from the carcinoma will go into the blood and start to activate coagulation factors and initiate clot formation and a DVT. And the last pillar of Virchow's triad is endothelial damage. So if we have endothelial damage, this can locally initiate a thrombus formation and a DVT. So now when we think about how a DVT will present, if we just take a look again at this diagram over here, because of that blood clot that's present, when blood starts to move and drain from the venous system, it can't get past the clot, and so it starts to back up, and so we're going to see pooling of blood in the affected extremity. And this pooling and engorgement of blood in the affected extremity is going to lead to unilateral leg edema if the DVT is in the leg, and erythema. Okay, so now we're going to be talking about the DVT diagnosis. So one of the physical exam findings that we may see when someone has a DVT is something called the Homon sign. And this is when we can get calf pain when the foot is dorsiflexed. So again, just taking a look at this diagram over here, we dorsiflex the foot, and this can elicit calf pain in the affected extremity. Now, one of the better tests to use is something called a Doppler ultrasound, and this is essentially just a radiology tool that can detect blood flow abnormalities in affected vessels. So like we described over here, if a DVT is present, then we're going to see impaired venous drainage through the DVT, and this can be picked up on Doppler ultrasound. And lastly, we can perform something called a D-dimer test, which will detect blood clot degradation products. So whenever we get the formation of a clot, the body will respond by initiating the degradation of that clot, and we could pick up those clot degradation products using the D-dimer test. Now, of course, there are many conditions that can result in blood clotting and clot degradation, and furthermore, there are some conditions that can actually result in a false positive D-dimer test. So in that regard, it's not the best confirmatory test for a DVT, so it's highly sensitive, but it's not necessarily specific to DVT. So the DVT itself is somewhat harmful, but one of the feared complications of a DVT is that it can lead to a pulmonary embolus. Okay, so let's just take a look at this vessel right here, and let's just remind ourselves that a thrombus is essentially a blood clot that has formed in situ. So where you find the thrombus is where that thrombus has actually formed. Now, the thrombus can get loose and detach and start to travel through the blood vessel and then get lodged somewhere else. and now we call it an embolus. So essentially an embolus is a thrombus that has traveled. So again, just revisiting this diagram over here, we discussed how a thrombus can form in situ in the deep veins of the leg. And then that thrombus can actually break off. And when it breaks off, it's going to travel upwards as the veins get progressively larger. We go from the deep veins of the leg to the inferior vena cava, which is larger in diameter. And then we actually get to the right side of the heart, where we go from the right atrium to the right ventricle. But from the right ventricle, now we enter into the pulmonary circulation, where the veins actually start to progressively get smaller in diameter. So now if we just zoom in on the lungs and we take a look at this diagram over here, we have the blood clot that's traveling up through the inferior vena cava. It enters the right atrium, then the right ventricle, and then it enters the pulmonary circulation via the pulmonary artery. But as the pulmonary artery starts to branch, the vessels become progressively more and more narrow, and eventually those vessel diameters are going to be more narrow than the clot diameter, and then the clot is going to become stuck in the pulmonary circulation. And so it's very classic that in a DVT, we can get the detachment of the thrombus, and the next most likely area that the thrombus is going to become stuck or lodged in is going to be the pulmonary circulation. Okay, so what exactly happens when the embolus is lodged in the pulmonary vasculature? So let's just remind ourselves, looking at this lung diagram here, let's say we have the cross section of a pulmonary vessel. The branches of that vessel actually perfuse a triangular or wedge-shaped area. And so if we have the blood clot or the embolus that's lodged in this vessel here, the affected tissue that's going to be distal to the embolus is going to be this wedge-shaped triangular area. And furthermore, let's recall that the lungs also receive a dual blood supply from the pulmonary vasculature, but also from the bronchial circulation. And oftentimes there's actually anastomoses present between the bronchial circulation and the pulmonary vessels. And so when we have a blockage here, blood is actually going to be redirected through these anastomoses, which is more blood than those vessels usually accommodate for, and that could lead to leakage of blood into this infarcted space. And so we call this a hemorrhagic infarct or a red infarct. And so we have that in the text. When the embolus is lodged in the pulmonary vasculature, this can result in a hemorrhagic pulmonary infarction, which is usually wedge-shaped. And this is true of most organs that receive a dual blood supply, and especially of the lungs, because it has very loose, airy tissue that the blood can easily seep into and occupy. Okay, so the clinical presentation of a pulmonary infarction is classically going to be sudden onset dyspnea. This is because a portion of the lungs is now infarcted and we can no longer use it, so it's hard to breathe. And furthermore, the infarction is going to be painful, so we can get chest pain. Now, of course, sudden onset dyspnea and chest pain is similar to a myocardial infarction, and so when you suspect a myocardial infarction, a pulmonary embolism should also be on your differential. Furthermore, other things we can see are cough, tachycardia. We can also get a mild hypoxia. This is because there's certain portions of the lung that blood is not going to anymore, so we're not oxygenating the blood as much. And furthermore, we can get a low-grade fever. This is because the infarcted tissue actually releases pyrogens that can induce a low-grade fever. Now, it's to note that these presentations here are classic for boards questions, but it's also classic for a large pulmonary embolism. Whereas if the pulmonary embolism is very small and not that much tissue is infarcted, the patient may actually be completely asymptomatic, and maybe the only presenting sign will be something like tachycardia. So it's just to note that depending on the size of the clot will determine the clinical severity. And on that note, there's also something called a massive pulmonary embolism. And this is where we get the partial or full occlusion of the pulmonary artery. And oftentimes we call this a saddle embolus. So if we just take a look at this CT scan over here, this is a cross section just above the heart. So right here, we can see this is the pulmonary artery, and the white is fresh blood. And this dark structure right here that kind of looks like a saddle, this is a saddle embolus that has lodged in the pulmonary artery and is now fully occluding the pulmonary artery. So of course, if we're partially or fully occluding the pulmonary artery, we're not going to be pumping much blood to the lungs, and this can result in severe hypoxemia. And furthermore, now blood is going to be backing up into the right ventricle, and so we're going to start to see right-sided heart signs, such as an increased right ventricular size and right ventricular dysfunction. So just taking a look again at this diagram over here, if we have a large saddle embolus that's occluding the pulmonary artery, now blood is going to back up into the right ventricle, expand its size, and once it's expanded, now it's going to start to dysfunction, and we can start to see things like arrhythmias. So some EKG findings that we can see: commonly, we can see sinus tachycardia, and this could be due to less blood flowing to the left side of the heart because of that embolus blockade. And so as a result, we're going to have less stroke volume in the left side of the heart. And so the heart is going to compensate for its cardiac output by increasing the heart rate. And secondly, because the patient may be anxious or in pain or hypoxic, we can get sympathetic stimulation, which will also increase the heart rate. Next, one of the common findings in a pulmonary embolism is something called S1Q3T3, which is essentially a deep S wave in lead 1, a deep Q wave in lead 3, and a deep inverted T wave also in lead 3. Now, I think being able to recognize this on an EKG might go a bit beyond what's expected of you in preclinicals. However, understanding a bit of the theory behind it may be useful. So this EKG finding is essentially an indicator of acute cor pulmonale, which is essentially right heart failure due to high pulmonary pressures. So in the case of pulmonary embolism, there's going to be very high blood pressures just proximal or just before the embolus, as blood pressure is backing up behind that embolus and then backing into the right ventricle and causing right heart strain and acute cor pulmonale. However, acute cor pulmonale can occur in other things such as pneumothorax or ARDS. And lastly, like we mentioned, as the right ventricle enlarges and expands, this is going to disrupt the conduction in the right ventricle, and so we can get arrhythmias. And one of the classic arrhythmias associated with pulmonary embolism is a right bundle branch block. Okay, so now let's talk about pulmonary embolism diagnosis. So one of the first tests we can perform is a ventilation perfusion scan. In this case, we would be injecting radiotracer dye into the patient so that we can visualize the perfusion of the chest. And in the area that's infarcted, the perfusion or the Q should be 0, and so the VQ ratio should be infinity, which indicates dead space. So if we just take a look at this ventilation perfusion scan here, this is actually taken from someone that was in a very hypercoagulable state, and so they have multiple blood clots, and we can see these areas that are not taking up radio contrast dye. This is because these areas are not being perfused or are infarcted because there are emboli lodged in the vasculature in these areas. And next, we can perform something called a CT angiogram, and the prefix angio actually means vessel, and so this is an imaging tool that's actually looking at the vessels themselves to detect clots in the pulmonary vasculature. Okay, so let's finish up by discussing DVT and pulmonary embolism management. So in someone that has recurrent DVTs or pulmonary emboli, we can install something called an inferior vena cava filter, and this is actually going to disrupt the clot passage from the veins to the lungs. So again, just looking at this diagram over here, if we install a little filter or a little catcher in the inferior vena cava, then if the patient does develop a DVT and it dislodges and starts to travel, then it will actually get caught in that filter and won't progress to the lungs to cause pulmonary embolism. Next, we can also administer warfarin and heparin, which are anticoagulation medications, and these are usually given prophylactically in patients that are at high risk for developing a DVT, such as patients that have prolonged hospital stays. And lastly, usually when someone has a massive pulmonary embolism and we really have to get rid of that clot, we could administer tissue plasminogen activator, or TPA, which acts via thrombolysis, or it's a thrombolytic medication that will degrade the clot. So remember, a classic boards question setup is someone that has had a long plane ride, a long car ride, or a prolonged hospital stay after something like a hip surgery, and now all of a sudden they're going into acute respiratory distress. One of the main things you should be thinking is they may have developed a DVT that has broken off and now has become a pulmonary embolus. All right, and that's all we got for our video on DVT and pulmonary embolism.